For those who I haven't met, my name is Sean Barinholtz. I am an anesthesia and critical care physician at Hopkins. I'm an active member of Pikesville Volunteer Fire Company, and I have the honor of serving as one of the medical directors in CAR 609 in Dr. Pollack's office, Baltimore County Fire Department. On behalf of the medical director's office, on behalf of the EMS office, Director Shenning, Captain Willits, Captain Stewart, Captain Natz, thank you for what you do. Thank you for your dedication to lifelong learning. On behalf of Ashley, big shout out to Ashley Brooks, who's online. Ashley is helping us run the Zoom platform. Ashley will also be sending out via the chat, so if you can see the chat function on the screen, she'll be sending out a link for you to click to get your CMEs. So if you're interested in your CMEs, keep an eye out on the chat function. Ashley will send out a link at some point during this talk. Click on that link, enter a couple pieces of information, including your accurate MIEMSS number. Please, if you're not sure about your MIEMSS number, see if you can get that so you can be accurate in putting that in. It'll be easier for us to give you your CEUs. I think that's about it. So thanks again for joining us. Tonight, it's such an incredible honor for us to be able to host Dr. Tim Chizmar. Dr. Chizmar is the State EMS Director for MIEMSS. Dr. Chizmar is a board-certified physician in emergency medicine and emergency medical services. Dr. Chizmar graduated from the University of Maryland School of Medicine and completed residency training in emergency medicine at the University of Maryland Medical Center and R. Adams Cowley Shock Trauma Center. Dr. Chizmar has practiced emergency medicine for over 10 years at the University of Maryland Upper Chesapeake Medical Center and previously served as Harford County EMS Medical Director and Region 3 Medical Director for the past 7 years. Dr. Chizmar, thank you so much for giving us your time and your talent. Thank you so much.
Thank you, Dr. Barinholtz. It's certainly my pleasure, and really, I'm quite honored to join you all this evening. I'm going to take just 1 second to, again, in addition to thanking Dr. Barinholtz and all the medical directors, as well as the command staff in Baltimore County, who have been wonderful to work with. I want to thank all of you for taking your time this evening and hopefully I'm able to give you a couple of key points to help you in your clinical practice, particularly with the care of trauma patients. So I'd also like to thank you, all of the EMS clinicians in Baltimore County, and those who may be attending from other jurisdictions, for all of your help during COVID-19. I know that this is an ongoing struggle, and I know that certainly the burden of personal protective equipment and having to consider that has been quite sizable, and it certainly doesn't go unnoticed. I know that the members of all of our communities really sincerely appreciate everything you do, and your time and volunteering, whether you're volunteer or career, really, and it makes a huge impact. So thank you. I am going to attempt to share my screen here, and just discussing with Dr. Barinholtz here, what I'd like to do is pause about midway through to see if there are any questions. If you do have any questions, you can go ahead and type them into the chat box at any time, and we'll make sure that we answer every question possible. And then we'll also pause at the end if there's any questions or discussion. I'd love to discuss this further if folks are interested. So without further ado, I'll go ahead and get started. So as it says up there, hopefully everybody can see the screen okay. At least it looks that way. I was privileged and honored to try and fill the large shoes of Dr. Rick Alcorta, who was with us for many years. I'm still feel like while I'm a little more comfortable, I'm still getting my feet wet on some days, and I certainly appreciate you guys having me. So what I wanted to talk to you about this evening is, cutely entitled "Don't Pop the Clot." So growing up as kids, our parents always told us, don't pick the scab, bleed, right? So when we're resuscitating trauma patients, we want to try and provide benefit to the trauma patient without destroying their clotting ability. We want to ensure that we're able to deliver the patient who's been adequately resuscitated to the closest trauma center in most cases. But also we want to follow the first principle in medicine, which is first do no harm, or primum non nocere. So I don't have any disclosures. I work for the state. I'm a state employee, and nothing interesting on that front. So the way of review this evening, as far as objectives go, I want to talk to you about our approach, and just by way of review, with regard to trauma care, there are roughly 3 peaks of when people die related to their trauma. 50% of the people, 50% of the people, die immediately on scene, and unfortunately, other than being right on the scene when the incident occurs, we're not able to provide too much medical care and impact for people who die immediately on the scene. However, we are able to engage in prevention efforts to try and prevent auto accidents as well as falls. The next 30% die within the next few hours or die early on, and we are able to do quite a bit to try and help those people, and that's the group that we're going to focus on tonight, and trying to reduce their mortality and trying to improve their outcome. And the remaining 20% die late in the game, usually from infection and things that are largely outside of our control in the pre-hospital environment. So this evening we're going to talk about a systematic approach to trauma assessment and resuscitation, and then I'm going to review 3 key areas. The 3 key areas are paying attention to our fluid resuscitation in shock, particularly patients that are in hemorrhagic shock. The next item we're going to spend a little bit of time on as well is what we should do about providing ventilation to our trauma patients. And then we'll spend the last amount of time discussing some emerging approaches and therapies that are coming out that you may have heard about or may have questions about. So does this scene look familiar to anyone? I know that we're not interactive, so that is a little bit of a rhetorical question. I took this picture actually when I was responding on a scene late one night in northern Harford County. This was about 5 or 6 years ago, but you could very well put this scene anywhere in northern Baltimore County, Carroll County, or just outside of the Beltway. So some of the things that we're thinking about when we approach this scene, besides, gosh, what a mess. How many patients are we going to have enough resources? Are we able to access the patient? Are we able to make access and actually start resuscitation, or do we need fire rescue to help us make access to this patient? And what is going to be our mode of transport? Is this someone that may benefit from aviation, or is this somebody we're going to transport by ground? But needless to say, this is going to be a common scenario for us across the state. The high-speed MVC with significant intrusion in the passenger compartment. And one of the first things that I worry about when I come up to this scene is this person going to be in hemorrhagic shock? Because that means that we've got a limited amount of time to do things effectively and efficiently. So most presentations are the case. And the first case I'll present you with is a 50-year-old male. He presents with multiple pain complaints, including abdominal pain and chest pain. He was in this car right here. He is alert and oriented ×3. You can see his vital signs there. And usually when we're together in a group, I sort of ask people, to react to those vital signs. But without further, I know we're in an online format. We do notice that he is a little bit tachycardic, heart rate of 110. Blood pressure is a little soft, 100/60. If his respiratory rate is actually 20, and this is sort of a running joke in EMS and emergency medicine, is did you stop to count the respiratory rate? But taking that his respiratory rate is really 20 and somebody counted, that respiratory rate would be tachypnic. He would be breathing a little bit fast. His oxygen saturation is just at the borderline of what we'd like to see, 92% on room air. Oops. Of note, the BLS crew arrived first on scene, and they got this one blood pressure reading of 80/50. But, they said, I'm not really sure if that was right or not. Maybe we ought to confirm it, but that's something I want you to keep in the back of your head as we go through this, is that any hypotension throughout the call really should not be ignored. We should be paying attention to that because it does have an impact on the patient's ultimate outcome. So we go through and we do our assessment, our systematic assessment. We find that his airway is intact, his breath sounds are equal, he has pulses in all extremities, and he's able to move all extremities. So, you know, that's pretty good. We're starting out from a reasonably good point there. But as you assess, you start to notice, and one key point, one thing I want to leave you with here tonight is to make sure that you are exposing the patient. So after A, B, C, and D comes E, exposure. And what do we find on his abdomen and his chest? This is something we call a seatbelt sign or a seatbelt contusion. So why do we care about this? This is not, you know, certainly 100% take it to the bank, but a seatbelt sign does portend at least a higher chance of internal injury, particularly bowel injury or mesenteric injuries that may be delayed. So we do want to take these patients seriously. We're taking all patients seriously, but this is something that when you see it, your suspicion should be just a little bit higher. The alarm bells should go off, so to speak, when you see this. This person has at least some higher degree of likelihood of having significant internal injury. So as I've kind of alluded to, our systematic assessment for trauma should be a primary survey, starting assessing the airway, breathing, and circulation, as well as for disability, and then exposing the patient. It's important that when we expose the patient, that we cover them back up. As I'll discuss a little bit later, one of the things that contributes to patients not being able to clot is hypothermia. So if the patient is uncovered for the primary survey and then starts to lose heat, they can become coagulopathic. They can start to have impaired clotting ability if they're hypothermic. So after the primary survey, we want to go head to toe with our secondary survey. And then importantly, we want to reevaluate the patient. Even if it's a short transport, we want to reevaluate their vitals and repeat the primary and secondary survey to make sure we haven't missed anything on our first sweep through. And then getting the patient to definitive care, and the right definitive care is obviously important, as we all know. So again, just to recap, remembering A, B, C, D, E, and the exposure with environmental control means don't forget to cover the patient back up to prevent hypothermia, particularly if we're in the spring, fall, or winter months. So walking through these systematically, as far as what our interventions may be, the first step is if the airway is not secure, they're not able to maintain their airway, some options for us are to consider the jaw thrust or suction or adding supplemental oxygen. Intubation is often debated, but I will tell you, as I'm sure you've heard many times before, that many patients can be appropriately managed in the pre-hospital environment with a simple BLS airway, with an oral or nasal airway, without necessarily having to go through intubation. You'll notice that I did not put down the head tilt chin lift here, on this slide because we want to maintain C-spine control and not tilt the patient's head back. So again, by way of review, when we're assessing for breathing, we want to ventilate with supplemental oxygen if the patient needs it. We want to be alert for any signs of tension pneumothorax, in which case we would consider decompression. And this is something that has changed just this past year with respect to adults, where we want to decompress on the side or the anterior axillary line so that we have a chance of success. We would still decompress anteriorly for any children less than 15 years of age. If the patient does have an open chest wound, we want to consider putting a chest seal on that, three-sided, so that it can be burped if needed. One of the most important things, again, as I said, when we walk up to that car, is if the patient is in hemorrhagic shock, one of the first things we want to do before we start talking about starting IVs or how much fluid we're going to give them or not give them is to stop the bleed. So I know Stop the Bleed has been very popular. It's been a very popular course. Again, just distilling it down, the first thing you can do is obviously after you've taken your BSI and applied your PPE, is to apply direct pressure to the wound. If it is a wound that's on an extremity and is amenable to a tourniquet and you can't control it with simple direct pressure, then certainly the tourniquet is appropriate. But if not, if this is a central wound on the torso, we have explicitly added this to the protocol, and this has been part of Stop the Bleed, is considering wound packing, where we get either medicated gauze, hemostatic gauze, or even simple gauze into the wound and trying to apply pressure deep in the wound to stop the bleed, and that's critically important. We're going to spend a good amount of time in this presentation talking about IV access and fluids, so I'll jump for now. Our last two steps, disability, assessing neurologic deficit. We want to consider whether or not spinal motion restriction is necessary. And what do I mean by that? That means in many cases that we're going to use a C-collar. It doesn't always mean we're going to use a backboard, though. Certainly if the patient is alert and there's no indicators of neurologic deficit, the patient's able to walk, we don't necessarily have to board and collar everybody. I would encourage you to be relatively liberal with application of the cervical spine collar. There's very little downside, but I would encourage you to be cautious and judicious with application of the long spine board. As you know, as time has gone on, we've gradually drifted away from that. And for good reason. We do know that the long spine board also, patients immobilized on the long spine board not only begin to experience pain with time, but they also end up getting more radiologic studies once they get to the hospital that may or may not be necessary. Certainly, if this is a multi-system trauma patient and this person is unconscious or has a depressed level of consciousness, we're still going to err on the side of caution and do the board and the collar. Our last step, again, environmental control, is to warm the patient and prevent hypothermia. And this is a key concept in trauma care, what's called the lethal triad in trauma. And again, you can see at the bottom here, coagulopathy, metabolic acidosis, where the blood becomes has a low pH and becomes acidotic. All of these things beget each other with time, and hypothermia is one of those things that we can directly at least control. So with that brief review of PH-TLS and to a degree ATLS, I want to dive into the meat of the discussion, which is how do we approach the patient who we suspect may be in hemorrhagic shock? So just to give you a little bit of a review, the scope of the problem of hemorrhagic shock, death from traumatic hemorrhage carries approximately a mortality rate of about 30%. That translates into 30,000 preventable deaths per year in the United States. If you think about it, that's roughly half the capacity of Raven Stadium. So we can do a tremendous amount of good for a tremendous amount of people if we address what is the primary cause of preventable death in civilian and military trauma, and that is hemorrhagic shock. So I know all of us have been around variable amounts of time. I'm certain that we have plenty of folks on the call who may remember this approach. And the approach was start 2 large bore IVs, as large as you can possibly get them, preferably in each AC, and run 2-liter bags of fluid as quickly as you can. And I'll tell you, while many of us became very proficient at that, what we were in effect doing is turning the patient's blood into Kool-Aid. We were turning them into Kool-Aid. We were causing them to have what we call dilution of the blood, dilution of the clotting factors, and in many ways we may have been impairing their clotting and impacting their outcome. So some of the new ways, and I put this up here cautiously because, believe it or not, in the scientific literature, people have been talking about limited IV fluid resuscitation all the way back to the 1940s and 1950s. But IV fluid resuscitation is something that we have added to the Maryland protocol this year. Just trying to give enough fluid to perfuse the head and perfuse the vital organs without turning the patient's blood into Kool-Aid. Now, it doesn't say Kool-Aid in there, but it'd be kind of cool if it did. As far as some of the new emerging therapies that we'll talk about are pre-hospital use of plasma, packed red blood cells, or component therapy. There are some EMS systems, and this is one that we actually have in development in Maryland, that are looking at whole blood. So whole blood is the blood, just like when you donate for the American Red Cross, that has not been split into its components. And again, there's a system, several systems that have started to use this with good results. And the last thing I'm going to talk to you about is a very inexpensive medicine called tranexamic acid, or TXA, which targets a very particular point in the clotting cascade, or the large sort of process of clotting. And we'll talk about the evidence both for and against TXA as we march through here tonight. So what about fluid resuscitation? As I mentioned, going back almost a century now, even prior to 1940, there was some scant literature dating to World War I. So all the way back to World War I, 100 years, the last pandemic. Permissive hypotension versus conventional strategy in adult patients. This review is a meta-analysis or compilation of many studies, multiple studies. And what these authors looked at was the 30-day mortality of patients, as well as their in-hospital mortality for patients that received either a conventional resuscitative strategy, i.e. open up the IVs and give them lots of fluid, or permissive hypotension, a restrictive strategy where we limit the amount of fluid the patient is giving. They also looked at the amount of blood products that had to be given during the patient's hospital stay. So looking through this, this is a compilation of studies, again, looking more specifically at penetrating versus blunt trauma patients. Some more recent literature from the 90s and 2000s, looking again at several hundred patients, targeting a goal, again, of a blood pressure of 100 or a MAP of 65. Some authors target a blood pressure of 90. And what they saw is that there was either a mortality benefit, in other words, fewer patients died, or that there was no significant difference between the groups that got more fluid versus less. So it's at least as good, if not better. I think we may have somebody who's not on mute. There we go. It's at least as good to target a lower blood pressure as opposed to just opening the fluid bags wide open. And I will highlight that this middle study here, Dutton et al. Was based at Shock Trauma, was based here locally. So there are several studies out there that say that a restrictive fluid strategy minimizes dilution. It minimizes coagulopathy. And by coagulopathy, again, we mean impaired clotting ability. That what we really should be doing is a balanced resuscitation and trying to achieve hemostasis or clotting until an anatomic repair can be achieved at the trauma center. And again, targeting a blood pressure of 90 to 100 systolic is just as good, if not better, than opening both bags of fluid all the way open. And you'll see that reflected in our Maryland protocol, where we say essentially, give small aliquots of fluid, no more than 250 mLs at a time, to try and achieve that blood pressure. And actually, I was getting a little bit ahead of myself. Provided that the patient does not have a suspected head injury, targeting a blood pressure of 90. If the patient does have a suspected head injury, targeting a slightly higher blood pressure of 110. And we'll talk about a trial in just a little bit called EPIC, in which the mortality benefit is there to actually keep just a slightly higher blood pressure for patients who have associated head injury. So again, your new targets are a systolic of 90 without head injury, or with head injury, a systolic blood pressure of 110. And before I sit on, for kids, there are age-specific blood pressures. I won't go into the detail, but again, we're trying to target the blood pressure at which the patient is perfusing their brain and perfusing their vital organs without fluid overloading them or causing impaired clotting. So diving into some of the newer literature here, this is a study from 2018 looking at some new modalities in the field, looking at the plasma component of blood, so splitting out just the clotting factors from the whole blood. And what these authors were trying to do is they were trying to say, is thawed plasma safe and efficacious for pre-hospital patients that are at risk for hemorrhagic shock? And their primary outcome that they evaluated was mortality at 30 days. So looking at 500 patients, they randomized 230 to plasma and roughly an equivalent amount to standard care, everybody from 18 to 90, and patients who were hypotensive, either severely hypotensive or had just a single isolated hypotensive episode. And if you remember back, my initial case was that 50-year-old guy who had an isolated blood pressure of 80 over 50. So in that trial, he would have qualified, in that case, he would have qualified having that single hypotensive episode if he were part of this study. And here's what they found. So looking at survival curves, the red line here is the group that received plasma, following them out all the way out to 30 days, and you can see that compared with the standard care group, these patients appeared to have a survival benefit when administered plasma early on in the pre-hospital environment. So again, they saw a lower mortality for patients treated with plasma at 24 hours and 30 days. The 24-hour mark is particularly important because I would argue that it's really the time frame that we have the most control over, is that first 24 hours and what happens to our patient in that first 24 hours. Importantly, they did not see any increase in infection or transfusion-related complications, and only a mild increase in minor allergic reactions related to the product administration. So this study, again, was called PAMPer, looking at plasma. We're going to shift just a little bit. Same group of authors, or very similar group of authors from Pittsburgh, also evaluated pre-hospital blood versus crystalloid or IV fluid in the severely injured patient. So they essentially looked at the same trial, and these folks actually had the benefit of carrying blood on their helicopters. And so they did a secondary analysis and said, well, I wonder if plasma is good, are packed red blood cells better? And furthermore, are packed red blood cells and plasma, which is in essence getting close to whole blood, essentially is whole blood, is that better than either of the two alone? So they looked at 4 groups: regular IV, patients who got IV fluid, patients who got packed red blood cells, patients who got plasma, and patients who got both packed red blood cells and plasma, and looked at their 30-day mortality. And wouldn't you know it, but the crystalloid line, which is the dashed line here, all the way at the bottom, and I'm not sure if you're able to see my cursor or not, I'm trying to highlight this for you, had the lowest survival of the 4 groups. Right up from that is the packed red blood cell group. Then right up from that is the plasma group, and the solid line up at the top is the packed red blood cells and plasma. Again, essentially approaching whole blood. So again, I think these studies tell us quite a bit about where we're headed with regard to pre-hospital resuscitation. And Dr. Flocare, who many of you know, is actively working along with several other medical directors to look at these modalities and how we can introduce them safely into the field. So again, we do think there's benefit. There are some cons or downsides or challenges, if you will, to implementing these programs that we'll speak about later on in the presentation. So again, what these authors found was any blood product resuscitation was better than giving IV fluid alone, that packed cells and plasma have similar reductions in mortality, but the combination therapy has an even greater reduction in mortality than either blood product by itself. So pretty powerful stuff. So I told you that plasma was good, packed red blood cells were good. I told you that putting them together was even better. So that begs the question, what about whole blood, where we essentially give the patient what they've lost? I mean, this seems like a very novel concept, but essentially what we're doing is giving the patient what they've lost, and essentially just ensuring that they're getting back in a balanced way what they lost. So it turns out that a group of authors has been very active in this arena in San Antonio. They started in January of 2018 with 18 helicopters. Many of you may know that we have an excellent aeromedical system that relies on the state police for scene transports. In several areas of the country, they have to rely on several commercial carriers to do the same job. But there are roughly 18 helicopters in greater San Antonio that we're able to carry. And I'll explain the acronym here. Low titer O positive whole blood. That's what the LTOWB stands for. And low titer refers to low antibodies within the blood, essentially making it less likely that the patient is going to have a transfusion reaction. So they carried 2 units each of low titer whole blood, O positive whole blood. And if you remember back to physiology, the one group that may have an issue receiving O positive blood are women of childbearing age. And so I'll spare you the detailed immunology discussion unless somebody really wants to have it, and let you know that aside from women of childbearing age, all of us can receive O positive whole blood without really a concern for a transfusion reaction. I'll briefly mention that the feared reaction in women of childbearing age is that you give them O positive blood, and if they are a negative blood type, they can develop antibodies against that positive blood. And when they do that, if they later become pregnant and have a baby who is a positive blood type, they can essentially there can essentially be harm or complication with that pregnancy. So it's very important that their finding here did not exclude women of childbearing age. You can see what their criteria are, roughly along the lines of what I mentioned in the Pittsburgh group, where they're treating hypotensive tachycardic patients, patients with positive FAST exams or positive ultrasounds in the field. And I will highlight that that's another area that's taking off in our state. We currently have 5 jurisdictions who have deployed field ultrasound that were in the process of deploying ultrasound to try and help guide the decisions in the field. So you can see, again, patients that were coagulopathic that are on a thinner, patients that are hypotensive or tachycardic. The only group that they excluded here were patients that were under 5 years of age. So just to kind of show you, at the top of the screen is your standard unit of packed red blood cells sitting next to a unit of whole blood. So you are giving a larger amount of volume because you're giving both the red blood cells and the clotting factors and the platelets, which you can see in the lower corner, the lower right-hand corner. You can see all of those components stacked up. And traditionally, our approach in the United States has been to separate the blood out into the components that the patient needs and to only give the patient what it is they need. If the patient needs platelets, give them platelets. But in the field, where we're losing whole blood, we don't have some unusual clotting disorder. it may make sense, as I'm showing you systematically through studies, to give the patient whole blood, essentially give the patient what they're missing. So you can see each unit of whole blood is equivalent to the unit of platelets plus clotting factors plus the packed red blood cells. This is what the San Antonio group did, and this is one of the challenges to rolling out pre-hospital blood products, is that pre-hospital blood products have to be used within a certain amount of time or they go bad, they expire. And so in order to have a successful program, you need to make sure that you're rotating your stock and not allowing blood to go to waste. I think all of you know that our blood banks are constantly looking for donors, and we certainly don't want to waste any blood, if at all possible. So what they did was, actually in their program, some of their donors were men, again, to try and minimize the antibody prevalence, men that actually worked for them, paramedics and firefighters that worked for them, and they started the program by having those folks donate. And then they used the blood, or had the blood rotated after 14 days into the hospital so that it didn't go to waste. And they called their program Brothers in Arms. And again, this is the only reason why this was men only, was to try and keep the prevalence of antibodies. It turns out that women do have a slightly higher prevalence of antibodies, was to keep the number of units of blood with antibodies down. So this sort of shows you their deployment model. San Antonio is here in the middle, roughly where it says Bexar, and they deployed blood throughout Southwest Texas, throughout their system. So this was a preliminary paper, sort of what they found. Again, they cycled the blood between their helicopter bases, between ground ambulances and the trauma center. They were able to cold store it, and blood has to be kept cold stored and then rapidly thawed as needed for the patient. So you both have to have cold storage as well as a warmer. They looked at 25 adults and 5 kids at this interim report. And again, they were giving them low titer O positive whole blood, mostly motor vehicle collisions. And this is what their mortality rates look like. And for those that are familiar with Maryland's mortality rates, I don't mean to sound boastful or arrogant, but we're comparing apples to oranges here. First of all, in a state like Maryland, we have decreased travel distance to a trauma center, whereas in Texas, you have much more significant travel time. So the mortality rate of 36%, and these were critically ill patients, is admittedly a little bit high. But if you look at their patient cohort, 5 out of 9 of their patients went into trauma arrest prior to the trauma center. And patients that go into trauma arrest, we know trauma arrest carries a very high mortality from blunt trauma in the field. So again, this is a very sick cohort. This is not all trauma patients or all comers. So in our population, our mortality rate may be similar, but you've got to keep in mind that the demographics and geography are a little bit different in Texas than they are here. Pediatric mortality rate of around 20%. They did not have any transfusion reactions. Their average air time in the air, was 37 minutes, which is at least double what the air time is most of the time around here. So they plan to expand within their ground units. I'm sorry, just skipping ahead just a little bit here. Sorry about that. What they're planning to do is an analysis of more patients as they go on with time. But certainly this is very exciting, I think, and really gives you a peek at the near-term future. So I'm going to cover TXA, and then we'll pause and see if there are any questions, and just give everybody a breather. So TXA, as I mentioned, is a drug. It's a pretty inexpensive drug. What it does is sort of the opposite, if you will, to what TPA does. And TPA is the clot-busting medicine that we give our stroke patients. So this is sort of the opposite of that. It prevents a compound called plasminogen from being converted into plasmin, and that plasmin essentially helps promote clot breakdown. The fibrin meshwork, if you remember, can be broken down into products. So if we apply TXA, we're essentially trying to slow that process of breakdown of fibrin clots. An important note is that the dosing is initially 1 gram over 10 minutes, but it does require a follow-up dose several hours later in order to be effective within the trauma center. So there are some researchers that have looked at TXA as well. A large trial entitled CRASH-2, where they looked at TXA versus placebo, and then they evaluated for 28-day mortality or complications, as you can see down there. One of the main risks of giving TXA or something like TXA is causing too much clotting or vascular occlusive events like MI, heart attack, or stroke. What they found is that in the group that was given TXA, there was a modest mortality benefit, 14% mortality, 14.5% mortality, as compared to 16% in the placebo group. Their p-value is significant there, meaning that it's less than 0.05. It is significant, but it is a small absolute reduction, small but real absolute reduction in mortality. They found that early treatment reduced death related to bleeding, particularly if the drug was given less than 1 hour and less than 3 hours. So again, 1.5% survival advantage, which translates into something called a number needed to treat of 67. That means, translated otherwise, that I would have to give this drug to 67 patients before I saw one person survive that would not have otherwise survived. And you might say that that's a lot of patients, but it's really not. In the medical literature, there are some things that we do where the number needed to treat, some common medications we give, where the number needed to treat is several hundred before we see one person benefit. Interestingly as well, the numbers are even a little bit better if the medication is given within the first hour as opposed to the first 3 hours. Some other TXA related studies, these are military studies in which they were giving TXA along with giving what's called a massive transfusion protocol or 10 or more units of blood. So the MATTERS trials, they did see some significant reductions in mortality, and they also saw some reduction with adding TXA. But so there's a lot of data that's very pro TXA, and what I would say to you is, if you are bleeding out on the side of the mountainside, side of the mountain, or in an austere environment, there's very little question in my mind that TXA would be of benefit to you. But as I'll show you in a few minutes, the civilian trials in a mature trauma system like our own question the generalizability of the CRASH-2 trial and some other trials. So I'll show you a couple of studies. I've shown you the pro, I'll show you the con. So do all trauma patients benefit? I think as the question implies, we're not quite sure. So this was looked at in the Miami, Florida trauma system. Over 1,200 trauma patients were given TXA who required emergency OR transfusion, and they evaluated and found increased mortality, 27% in the TXA group, or versus, I should say, 17% in the non-TXA group. And one thing I would put in here as a caveat is, with all of these studies, there is some selection bias. So you have to look very closely at how sick their group of trauma patients is. And I would again say requiring an emergency operating room procedure means that this cohort of patients was quite sick. Also, you'll note the TXA was given over at 97 minutes, exceeding an hour. So again, that is something to keep in mind. What I will show you here, though, is in the mature trauma system in France, about 1,500 patients that they found that TXA was not associated with a reduction in hospital mortality. However, they did find improved survival in the cohort of patients that required blood transfusion while in the ED. So a mixed study at best. Looking again at France, another group found in 2015 that there was support in their trial for efficacy and safety and survival advantage, particularly when evacuation to prompt surgical care may be delayed. So I think there's less debate about its use in the austere or rural environment. The question is, in a mature trauma system, what role does it play? So the other con is, again, this is the same group that looked at plasma as well as packed red blood cells, Dr. Peitzman's group out of Pittsburgh. They looked at the risk of thromboembolism, and they found that in their group, there was a threefold increase in blood clots or venous thromboembolism. And that risk remained high despite adjusting for accounting for mortality, and they also adjusted based on injury severity score and a bunch of other factors. So again, Dr. Peitzman's group in this study found that there was no associated survival benefit for TXA at least in the Pittsburgh trauma system. And again, they suggest, largely along the lines of what I suggest, which is that we need more study on an individualized approach. In other words, who are the patients that we should be giving this to, and what is the timing? So I would say, again, there are several studies that show survival benefit for TXA, particularly when given early, particularly in a military or austere environment. However, there are equally important some studies that show an increased risk of blood clot, an increased risk of mortality in the civilian setting. And again, the jury is still a little bit out on TXA, even though some states and regions have started to adopt it. This is something that we at MIEMSS, as well as the Protocol Review Committee, are actively pursuing and actively evaluating for Maryland. We certainly, again, want to follow the same principle of first do no harm. So Dr. Barinholtz, I'm going to pause there and visit the chat box,
Great.
as well as any questions that you may have received. If I can get the chat box, let's see. Oops. There we go. So Jay Clements, maybe Jim Clements, says, discuss the role and value, if any, of positioning. So one of the things, Jay Clements, and I'll say I don't want to assume, one of the things that's important to keep in mind, as you've highlighted, is perfusing the head. So the degree to which we can keep the patient either flat to 30 degrees, absent other factors. In general, if the patient is hypotensive, will help perfuse the brain. Now, certainly if we have a head bleed as part of the injury pattern, we may want to elevate the head of the bed just slightly, or at least the head slightly, provided we can do that with the C-spine immobilized. If we do have that patient on a long spine board, we can elevate the entire long spine board just a little bit to try and reduce the intracranial pressure. And Tina has helped me out. She's realized that I'm less computer literate than many, so I appreciate that, Tina. The next question from iPad 9 is there any role for epinephrine in trauma? There's extremely little role for epinephrine in trauma, except in one of the very few cases that I would highlight is if we think the patient is in neurogenic or spinal shock. We do know that spinal injury patients do not tend to do as well with lower blood pressures. And if we can keep that spine perfused, it generally tends to help them. So there's a very limited role. There is really not a great role for it in trauma arrest, I will say. And for those of you that have taken a look at our new protocols, you'll see that even in a medical arrest, we have de-emphasized and we've essentially said that at about 4 doses, we're just giving doses of epinephrine and we're vasoconstricting the patient, their cerebral vasculature. So on the off chance that we do get that patient back, what we get back is a brain dead patient. And I'm grossly oversimplifying, by the way. Alyssa, no problem. You're unable to see the chat using the mobile app. I'm not sure, Dr. Barinholtz.
I think she's okay.
Okay.
Yeah.
Good deal.
She texted me.
Another great question, I think, from Sam Weinstock. Would Maryland ever do a pre-hospital trial for TXA for trauma and medical, for that matter, to obtain more research and studies? And Sam, you must have a bug in my office. So that is something that we hope to work collaboratively with the trauma centers on, because frankly, some of the leading trauma surgeons in our state strongly believe that, again, the cohort that benefits is not defined, and particularly in the urban areas, benefit is less clear. So that is exactly our aim with our trauma centers. At the same time, question number 2, if Maryland were to incorporate blood, plasma, PRBCs, would be also administer calcium chloride to those patients typically being hypocalcemic, from what I understand. So yeah, that is a concern. As you give blood product that has significant amounts of citrate in it, the patients can become hypocalcemic. Generally speaking, with our transport times, that really should not become an issue for us in the field. That would be an issue really, down the line for the trauma centers to have to address, and they're very familiar with doing that. From Chris Parker, do PRBCs or plasma have any effect on patients with bleeding disorders such as factor V? So that's a great point. So that is part of the drawback, is that a lot of these patients, we don't have the luxury of getting a good history from them. And I would say in general, no. For packed red blood cells, no. Factor V mutations, it is a balance of risk versus benefit, particularly with things like TXA. TXA is targeting a different area, but we do know that people that have certain factor deficiencies or factor excess or factor mutations may be coagulopathic. But what many would argue is, because we don't have the opportunity to get a full history and the patient's bleeding out, that we may have to do what we have to do, and the more imminent risk to them is the hemorrhagic shock. And it looks like Sam has said thank you, and Chuck Bollinger is saying, is there a sign-in link for tonight?
We'll take care of the sign-in. Thanks.
Yep. So thank you, everybody. These are really wonderful questions. I'm really quite impressed, seriously. So we spoke a lot about, and the main thrust of the talk is preventing clotting. Preventing coagulopathy, really preventing, we don't want to harm the patient's ability to clot. But I do want to spend a couple of moments, because we do have patients, trauma patients in particular, that we ventilate. And I think we need to address the general approach to ventilation as well as part of the whole package. There we go. So one of the things that you're starting to see gradually go away little by little and year by year is this concept of hyperventilation. So hyperventilation in general was felt to decrease the intracranial pressure, and it does that. It actually does reduce the intracranial pressure. The problem is that it does it by reducing the amount of blood flow to the brain. It essentially causes cerebral vasoconstriction. So I'll remind everybody that we have three things inside of our skull, I think, most of the days, right? We have brain, we have blood, and we have CSF, or cerebrospinal fluid. And so if any one of those things starts to expand, the skull is a rigid case. If one of those things tries to expand, short of a neurosurgeon, we're very limited in our ability to prevent the buildup of pressure. So historically, we've hyperventilated these patients, and we've vasoconstricted them, and we've reduced the pressure in their skull. But again, it can come at the cost of blood flow to the brain. So you'll see in our protocol currently, really hyperventilation is reserved for imminent herniation. And what do I mean by that? I mean the patient that blows their pupil right in front of you, where that person is at extremely high risk for a poor outcome. And you could say that this is the Hail Mary, so to speak. But in general, hyperventilation in head injury is not such a great thing as I'll talk to you about. So failure to control, several authors have looked at this, and failure to control post-intubation hyperventilation is associated with a 6-fold increase in mortality. So forget what I told you about the head injured patient who's herniating. What about the patient that we intubate who's unconscious? And now we've got a nice highway, an endotracheal tube, that allows us to effectively hyperventilate the patient very easily. So what I will say is, over the years, there have been several authors that have said it's the act of intubation that increases mortality in this patient cohort. The question I really have is it really the act of intubation, or is it that intubation allows us an easier method to hyperventilate somebody? And if you're not an anesthesiologist like Dr. Barinholtz, and you're not the most proficient with holding a seal, when you're bagging someone with an oral airway in place, it's not so easy to hyperventilate them because you actually have to work to hold a seal. But once you've got that endotracheal tube in place, you can just squeeze that bag all day long because you've got a highway right into the lungs. So I would contend that some of this increase in mortality in intubated patients may be due to the fact that it's just easier, frankly, to hyperventilate people who are intubated. And this group of researchers in Arizona have a large trial called the EPIC TBI trial, where they particularly looked at this in traumatic brain injury patients. So to review briefly with traumatic brain injury, several million ED visits, hundreds of thousands of hospital stays, 52,000 deaths, and 60 billion with a B in costs. The idea that we can and need to do better with traumatic brain injury is certainly on the minds of academicians, physicians, and people who pay for healthcare for sure. So this idea that a bundle of care or TBI guidelines can improve outcome is certainly very appetizing. And the way that this kind of links to what I was talking to you about just a second ago with ventilation is that these researchers in the EPIC trial, EPIC stands for Excellence in Pre-Hospital Injury Care, what they found is that what is most useful, and these are one of the points that if you leave here tonight remembering nothing else besides that guy Chizmar is boring, I want you to remember the avoid or treat the 3 H-bombs. And the 3 H-bombs are hypoxia, hypotension, and hyperventilation when it comes to patients where we have traumatic brain injury involved. These are 3 things that we can affect directly in the field and have a direct impact on the patient's mortality. So Arizona, much like we do, implemented statewide TBI guidelines. They don't have necessarily a statewide protocol for everything like we do, but they implemented statewide TBI guidelines that essentially said, avoid the 3 H-bombs. And I'm going to ask somebody to list those at the end of this, the pop quiz. And they track survival to hospital admission, which EMS can more directly control, and as well as survival to hospital discharge. And what they found is that their bundle, the implementation of their bundle, was significantly associated with increased survival to hospital admission. It was not associated with survival to hospital discharge. However, what I will say is it was not associated with hospital discharge across the board, but it was associated with improvements in hospital discharge in the moderate to severe TBI cases. And again, we're talking about GCS less than 13 cases here. In that sicker cohort, it did show some benefit. But what I will highlight as well is that the survival to hospital discharge also depends on how good of a job the hospital does, not just EMS. What they saw most importantly is in the severe TBI group, so the sickest group of patients they had, that survival doubled that patient cohort. And even more importantly, survival tripled in the cohort of severe TBI patients who were intubated. So remember what I said about that endotracheal tube being a highway and an easy means to overventilate somebody? This study would suggest that there might be some merit to that argument. So back to our case, way back to our case, our 50-year-old guy who was in the MVC. We cut the roof off, we got him out. He was found to have splenic and liver lacerations, as well as an intra-abdominal bowel injury. We assessed him for head injury. We did not find any evidence of head injury, at least on this guy. Depending on what we found, we would tailor our IV fluid resuscitation to a systolic blood pressure target of either 90 for multi-system trauma without a head injury, or 110 if we think we have a head injury on our hands. Again, there are some emerging pre-hospital therapies that we may see particularly rolled out in the aeromedical world as time goes on that may even improve the patient's outcome even more so than limiting crystalloid. So to bring things to a close this evening, I wanted to leave you with some take-home points, and I certainly am open to discussion and more questions. Some take-home points: what you can do tomorrow on the next major trauma case you run is to limit the amount of IV crystalloid or IV fluid, IV lactated ringers that you're giving during your resuscitation, and titrate that to a systolic of 90, unless you think you have a head or high C-spine injury on your hands, in which case you want to titrate just a bit higher. I think all of us are excited for some of the emerging pre-hospital therapies for resuscitation, and certainly it is the goal of the Maryland EMS system, particularly MIEMSS, to engage in more research than perhaps we have in the past, to try and help contribute to the scientific literature and answer some of these questions as to what is useful and what is not useful. Again, I don't want to rain on anyone's parade or steal anyone's thunder, but I can tell you that there are a few systems, including the aeromedical system, that are actively evaluating pre-hospital blood products, whether plasma or whole blood or PRBCs, and trying to get through those logistical challenges as we speak. And the last three things, again, we want to target a blood pressure of 90 or 110, but we don't want frank hypotension. We certainly don't want to tolerate blood pressures of 60 or 70, in which case we're just not perfusing the head at all. We also don't want to tolerate hypoxia or hyperventilation, with the one caveat of the imminently herniating patient where there is very little left that we can offer the patient. And with that, my email address is here. It's certainly on the MIEMSS website as well. I'm always happy to get questions. I can answer some of them, and the ones that I can't, I would try to get you answers for. So with that, Dr. Barinholtz, I will turn it back over to you, and we can run the chat log.
Thanks. I'm just trying to find myself on this screen. So sorry. There you go. Yeah, thanks. Thank you so much. That was amazing. What a great review of the literature. Thank you for your dedication to pre-hospital providers, for advancing this science. How exciting. What a great review of these studies. That's excellent. Hey, I do have a question while others may chime into the chat because I don't see anything, but I think people are chatting with you privately as well. So you kind of hinted that you are very interested in some studies for tranexamic acid across the state. That's super exciting. What else is on your wish list?
Yeah, so I kind of hinted at tranexamic acid as well as frankly, evaluation of pre-hospital blood products, particularly, and not exclusively, but particularly in the aeromedical environment where there is a sicker patient cohort, but not exclusively. The other thing that I think we can do, and consensus willing, one thing that I'm challenging the protocol review committee to do is to consider making the pelvic binder, which is now an optional protocol, a mandatory protocol, because I do think clearly that is one way that we could stop the bleed internally that some jurisdictions are benefiting from. There's good evidence to support pelvic compression if there's high risk of pelvic injury. And some jurisdictions, of course, the downside that has to be weighed is cost. When you have several, when you have 40 or 50 ambulances, it starts to add up, just being a realist. But I do think that is something from, at least from the trauma perspective, that, the short-term radar screen.
Great,
and you're right. I didn't realize that it was a private chat, so I'll go through some of the chat questions here. The first question is from iPad 9. Would it be appropriate to call a helicopter upon arrival to a scene like this because you're not sure how long it will take to extricate the patient? So that's a great point. And I would say, with everything, including the use of an aeromedical resource, you want to really identify the risk versus benefit. And if there is certainly a benefit to the patient, in other words, that would offer them a timely transport, that would exceed your ability by ground, I would certainly entertain that if you're unsure how long it takes to extricate the patient. I would say in general, just given the ramp-up time, if you're within 30 minutes of the trauma center, there's going to be very little benefit to calling the helicopter. But clearly, if you're going to be on scene for 30 minutes and then have a 15-minute transport, that may afford the patient some benefit. So I do review, just for everybody's knowledge, as does Dr. Flowcare, we do review the helicopter utilization database every day. I get a report at 10 a.m. and 10 p.m. And I will tell you that we run several patients per day that may not benefit from the helicopter, to be frank. But most of our patients, I think, our EMS clinicians are using the helicopter appropriately. And Robert Gold has a good comment here. He said, would you go so far as to add a fourth H for hypothermia? And I think that's a great point. That's a great point, Robert. So certainly something that could impact mortality as well. And from Jeff, we have, should we still consider hyperventilating head injured patients 20 per minute? Again, Jeff, I would reserve the hyperventilation for someone who you suspect not only has a low GCS, but is imminently herniating. They're showing you signs of blowing the pupil or posturing. I would use that very, very sparingly. In fact, there was significant debate among the physicians in the state about whether or not to completely take hyperventilation out and not even include that. And so what I will tell you is the pendulum is moving that direction, all except for people who are imminently herniating, in which case it's very much a Hail Mary, to be honest. From Jay Clements, thank you to Robert Adamski, for sure, thank you. From Jay Clements, you mentioned medicated gauze, i.e. quick clot for wound packing. What is the increase in patient value versus regular gauze versus cost? So Jim, I apologize. I can get back to you on that. I do not have the updated cost figures. I do know that some of them have come down significantly, but I apologize that I'm not prepared to give you a good answer. What I can say is that all is not lost. If you do not have hemostatic gauze in the Stop the Bleed program, they actually talk about taking your T-shirt and stuffing it in the wound, and the value is greatest for actually getting direct pressure on the bleeder. Certainly, there's a marginal benefit for hemostatic gauze, but I apologize. I don't have the studies in front of me, and I don't want to give you bad answers. So hemostatic gauze is something that we in the Maryland system can carry, but are not obligated to carry at this point. From Risa, hopefully I'm saying your name correctly, Risa or Risa Pegler. Is it okay to pack abdominal wounds? I thought it was reserved for junctional injuries. Again, very much so. If you are not able to control the bleeding from a wound to the torso or the neck for that matter, an area that can't be, cannot have a tourniquet applied, it is far better to try and obtain hemostasis. And certainly the hospital, for somebody with an abdominal wound, is going to load them up on IV antibiotics. And in general, unless it's a very superficial wound, many of these patients go to the operating room. So yes, indeed, it is okay. Again, keep in mind your goal is not to just pack the wound for the sake of packing the wound. The goal is to stop the bleeding if there's bleeding going on. And Sean, that is the extent of the questions in the private chat.
Yeah, that's what I see as well. Real quick, Ashley, can you send out the link again, please, for everyone? And then there's another provider, Captain Stewart, who's trying to say something. Let me see if I can figure out how to.
Is it my good friend Lenny?
Yes, Dr. Chizmar, can you hear me?
Lenny, what's going on? How are you?
How are you, sir? Long time no see.
I know. Len and I rode the medic unit in Bel Air long ago.
A little bit ago. A little bit less changed since then. Dr. Chizmar, I don't really have a question for you. I just wanted to thank you for your time. I wanted to take advantage of getting the word out while we have such a collective group. Dr. Barinholtz and doctors such as yourself are putting a lot of time in this, and I just want to ask the group as a whole that are watching tonight, if you could please just spread the word. We try very hard to get this out. We're certainly going to put it on the LMS, and people will be able to watch it after the fact. But those of you that attend these regularly know that the quality of education you get is far beyond anything we can give in the field. And if you're watching it, please just get the word out when these come along that this is an excellent opportunity for you to talk to the physicians and the experts in subject matter one-on-one with questions. And you're not going to get that on the LMS. You're not going to get it anywhere else. And I'd like to see, even though the attendance is good, I'd like to see us really take this attendance up and take advantage of this opportunity. So thank you again for your time. I know you're very busy. Good seeing you again, at least in this forum, sir. And Dr. Barinholtz and Ashley, as always, thank you for what you do.
Thank you very much, sir. It's always a pleasure, seriously, and I'm honored that you guys had me on. I mean, I will say that the reputation of the program that Dr. Barinholtz, particularly and others in Baltimore County, the command staff have built is certainly out there. So people are taking your advice and getting the word out, which is great.
Thank you, sir. Have a good night.
Captain Stewart,
You
you have
too.
always been an amazing supporter of this program, helping to advocate for it. You are the sole person responsible for posting to the FRA site. You're making that happen. So thank you for your support and what you're doing to make this happen.
Thank you also, sir. Have a good night, everyone. Be safe.
Thanks, everyone. Ashley, Tim, thank you. Thank you so much. Quite an honor. Thank you.
Thank you. Thank you again, Dr. Barinholtz. Pleasure to be on with everybody. And I hope everybody is well and you stay safe out there.
Thank you. Be well.